So hi guys, I just want to explain you kidney pathology. Let me introduce today's new topic to you. The history of renal pathology can be divided into two eras, one starting with the invention of the microscope and its application to renal tissue, the second one with the introduction of the renal biopsy, which coincided with the development of electron microscopy and immunofluorescence microscopy that allowed the analysis of pathological changes in great detail with an eye for pathogenesis and pathophysiology. These two eras started in 15th century with the works of scientists like Marcello Malpighi, Giovanni Battista Morgagni, William Bowman, Richard Price et al., which opened the new direction of kidney studying, which gave the basic information of the normal kidney structure, which gave us possibility to help to the patients with the kidney pathology. Normal kidney structure guides includes the anatomically structure and histologically or macroscopically structure. Of course, anatomically, kidney consists from the cortex and medulla layer. Medulla layer guides present renal medulla is composed of from 8 to 18 cone-shaped renal pyramids with the base of adjacent to the other cortex and form the corticomedullary junction, which opened in the renal papilla and contains the opening of the each renal pyramids to the minor calyces at first, and then into the major calyces and into the renal pelvis. Renal cortex guides contains from the glomeruli and of course from the tubules. Nephrons is the structural and functional subunit of the kidney parenchyma, and of course the renal cortex includes the following structure like the medullary veins. You can find this rays here, and of course with the renal columns of Bertine, which contain the interlobular arteries. Of course, the morphological structure of kidney opened the functional possibility of this organ, like excretion of the waste products of metabolism, regulation of body water and salt, and maintenance of acid balance, secretion of a variety of hormones and prostaglandins. The CT scan of the kidney structure give us information that kidney are paired structures and located into the retroperitoneal space and surrounded by the adipose tissue. Normally, kidney are symmetric in size and in shape, and CT scans guys can provide more detailed information about the kidney than standard kidney, ureter, and bladder X-rays examination, just providing more information related to injuries and diseases of the kidneys. CT scans of the kidney are useful in the examination of one or both of the kidneys to detect conditions such as tumor or other lesions, obstructive conditions such as kidney stones, congenital anomalies, polycystic kidney disease, accumulation of fluid around the kidney, and the location of abscesses. And of course, we can come to the normally histologically microscopically kidney structure. Glomeruli, from which consists the nephron, like the structural and functional subunit, divided on two poles, urinary pole and vascular pole. And of course, the structure of glomeruli guides includes the capillary tuft fed by the afferent arteriole and drained by efferent arteriole. The cellular compositum of the glomeruli consists from the following cells: like two types of epithelial cells, like parietal cells, which cover the Bowman's capsule, and the podocytes, like the visceral epithelial cells, and of course the endothelial cells, which cover the capillary lumen, and mesangial cells and mesangial matrix. Of course, the mesangium is continuous at the hilum uh, with the Lasik cells of the juxtaglomerular apparatus. The major function of the glomerulus is complex filtration from the capillaries to the urinary space. Glomerular filtrate is quite similar in composition to plasma but lacks proteins and cells. The barrier to glomerular filtration consists of the following three components: the fenestration, endothelial between endothelial cells of the basement membrane, which consists from three layers, and of course the processes of the podocytes, of the visceral epithelial cells, with filtration slit pores between the food processes. The filtration slit pores of the fenestrating endothelial cells is from 70 to 100 nanometers, and filtration slit pores between the processes of the podocytes, it's normally from 20 to 30 nanometers. You can find here to the capillary lumen, which opened with fenestration in endothelial cells, and of course I can draw your attention to the mesangial matrix with mesangial cells. Kidney biopsy under the electron microscope gave us possibility to increase the filtration barrier structure and the kidney parenchyme components in 2 million times. And of course, guys, you can find here the endothelial cells, the mesangial cells, and of course the filtration barrier structure, like the podocytes with the processes of the podocytes, and the basement membrane, glomerular basement membrane structure. Classification, guys, of all pathology of kidney pathology includes the next diseases, like glomerular diseases, diseases affecting tubules and interstitium, diseases involving blood vessels, like atherosclerosis, for example, or arterial hypertension with the primarily shunting kidney development, chronic kidney diseases, cystic diseases of the kidney, urinary outflow obstruction, congenital and developmental anomalies, and neoplasms. Clinical manifestation of the kidney pathology come with the azotemia, with elevation of the blood urea nitrogen and creatinine levels, largely due to decreased glomerular filtration rate, which divided on two types, like prerenal and postrenal azotemia, guys, and uremia, like the constellation of clinical signs and symptoms associated with azotemia. These include not only gastrointestinal, endocrine, metabolic, or hematologic or neural effects, and cardiovascular effects too. You should to know, guys, that the clinical presentation of renal disease invite to the acute nephritic syndrome and acute nephrotic syndrome. Of course, asymptomatic hematuria or proteinuria, which combination of these two, and usually with manifestation of the subtle or mild glomerular abnormalities, acute renal failure or chronic renal failure, which development under these clinical manifestations of renal disease, and of course the renal tubular defects, which are dominate with some another symptoms like polyuria, nocturia, or electrolyte disorders, and of course nephrolithiasis, urinary tract obstruction, or urinary tract infection. Clinical manifestation with nephritic and nephrotic syndrome, guys, includes another symptoms like hematuria or development of red blood cells casts, hypertension, azotemia, oliguria, and proteinuria with more than 3.55 grams per day under the nephritic syndrome. And nephrotic syndrome opens with the severe proteinuria, hyperlipidemia, generalized edema, and of course hyperlipidemia with lipituria. Nephritic syndrome, guides development with the inflammation of the glomeruli, and of course with development with hematuria, with generally slight, given the urine smoky appearance, and erythrocytes are detected by microscopy or by chemical testing for hemoglobin, proteinuria, and with the usual non-selective nephritic range proteinuria, and hypertension, which depending upon the severity of the glomerular disease, and of course development the edema in nephritic syndrome, with usually will be like results from sodium and water retention. And the last one, oliguria, is variable and reflects the severity of glomerular involvement. Nephrotic syndrome, guides, which come with hyperalbuminemia and hyperlipidemia, and leads to massive proteinuria and peripheral edema. Heavy proteinuria, which development under the nephrotic syndrome, of course characterized with the increasing of glomerular permeability to plasma protein. Excess of protein is filtrated out, extending the capacity of tubules for reabsorption, and of course therefore appears in the urine. And another type of protein loss is its selectivity. So hyperalbuminemia with the inadequate hepatic synthesis of albumin. You know how much albumin produced healthy liver, how much albumins we can find in plasmas, between plasmas proteins per day, so from 10 to 12 grams per day. And the concentration of other proteins in the plasma, such as immunoglobulins, clotting factors, and antithrombins, may fall to this patient, and thrombotic and thromboembolic complications come with this situation too. Edema, which development under the nephrotic syndrome, guys, it's always like peripheral edema, or can development paraorbital edema. How do you think? Why paraorbital edema? Because you know that the connective tissue of the paraorbital skin is more loosely than another connective tissue. So the loose connective tissue come with edema edema, development edema very quickly with this loose connective tissue. Hyperlipidemia, guys, which development under the Nephrotic Syndrome. So the exact mechanism of this hyperlipidemia today is not clear, but we have so much hypotheses to development of hyperlipidemia, and of course one of them includes the stress of massive protein synthesis, which have liver, and so the increasing of synthesis of lipoproteins, increasing of blood levels of total lipids, cholesterol, triglycerides, and another fraction of lipids in blood leads to hyperlipidemia. And of course, to lipiduria occurs the following hyperlipidemia due to excessive losing of glomerular filtration barrier, and hypercoagulability, which development under this syndrome, which can lead to arterial or venous thrombus, and can include increasing of urinary loss of antithrombin factors, and of course development the platelets, the increasing of platelets aggregation, and altered levels of some proteins. Clinical manifestations of acute kidney injury can dominated by oliguria or anuria, and recent onset of azotemia. It can result from glomerular injury. So, chronic kidney disease, guys, characterized by prolonged symptoms and signs of uremia, is the result of progressive scarring in the kidney, and of course it can culminate in the end stage. And end stage of the renal diseases is always irreversible, of course. We can speak about the loss of the renal function, and of course to requiring the dialysis or transplantation, typically due to severe progression, scarring in the kidney from many cases. The urinary tract infection can affect the kidney or bladder with the pyelonephritis and cystitis pathology development. There is pyuria and bacteriuria, but symptoms are variable. And of course, nephrolithiasis or calculi stones in the urinary space is manifested by renal colic and of course by hematuria. Glomerular diseases, guys, includes the primary glomerular diseases with development of minimal change disease, focal segmental glomerulosclerosis, FSJS, membranous nephropathy, acute post-infections glomerular nephropathy, membrano proliferative glomerulonephropathy, and immunoglobulin A nephropathy. Glomerulopathy secondary, which development with systemic diseases like lupus nephritis or systemic lupus erythematosus, diabetic nephropathy, amyloidosis, Goodpasture syndrome, or secondary glomerulopathies, microscopic polyangiitis, Wegener granulomatosis, bacterial endocarditis, for example, or thrombotic microangiopathy. And of course, the hereditary disorders, which includes the greatest three: the Fabry disease, Alport syndrome, and podocytes lead diaphragm protein mutations. The response of the glomerular injury come always with hypercellularity, guys. What does mean hypercellularity? It's proliferation of mesangial, for example, cells inside mesangial matrix or endothelial cells. infiltration of leukocytes, and of course at the end the formation of crescents. The answer of this hypercellularity will be the thickening of the basement membrane and of course the development of hyalinosis and sclerotic changes. Classification guides of primary glomerulopathies includes the at first depend on histological changes, which includes the diffuse changes with involving all of the glomeruli in the kidney, the global changes which involve in the entirety of individual glomeruli, and of course focal, segmental, and capillary loop or mesangial. The last one is affecting always the predominantly capillary or mesangial region, and of course can development under the primary glomerulopathies. Under the immune mechanism of glomerular injury, we can classify pathology on the next one. So, antibody-mediated injury, and this type of injury includes the immune complexes deposition, which development in situ, and during the circulating immune complexes deposition. What does it mean, guys? You know that in situ development immune complexes, when we have the deposition of immune complexes subepithelial cell and inside glomerular basement membrane. Circulating immune complexes deposition come always in subendothelial part. So the first one, immune complexes deposition in situ. So development in mesangial antigens fraction, and of course in the type 4 collagen antigen, and membranous under the membranous glomerulopathy with the fraction of antigens. Planted antigens, guys, divided into types like exogenous and endogenous. And exogenous antigens, it's always infections antigens, or for example toxic effects with Tract antigens, and of course endogenous factors includes the nuclear protein, immunoglobulins and immune complexes, and immunoglobulin A complexes. Circulated form of the immune complexes which development subendothelial, divided on two types, endogenous and exogenous too. And of course, cell-mediated immune injury, we can describe here like pattern and activation of alternative complement pathway. Diseases which caused by in situ formation of immune complexes so are formed locally by antibodies that react with intrinsic tissue antigens or with extrinsic antigens in the glomerulus from the circulation, for example under the membranous nephropathy. How it look like, guys? So I can show you some circulating form of immune complexes deposition. You can find here subendothelial, yes, most of all subendothelial, and in situ development the inside glomerular basement membrane, and this deposition we can find too between the processes of podocytes like in situ fraction. Diseases which caused by in situ formation of immune complexes. These pattern guides we can use here like the pattern of immune deposition by immunofluorescence microscopy, which is granular rather than linear. You can see here on this picture. And of course, reflective of the very localized antigen-antibody interaction. Diseases which caused by antibodies directed against normal components of the glomerular basement membrane. In anti-GBM antibody, it's in situ deposition too, and in dust glomerulonephritis, antibodies bind to intrinsic antigens which distributed along the entire of the glomerular basement membrane. And of course, in result, in a diffuse linear pattern of staining for antibodies, we can found this pattern under the immunofluorescence method too. How it look like this antibodies deposition, you can see here on the picture. And we can come to the next type and next pattern of glomerulonephritis, which caused by circulating immune complexes. What does mean circulating immune complexes? I just want to repeat to you guys, and I'll draw your attention that these complexes deposits subendothelial. So glomerular injury here caused by the trapping of circulating antigen antibody complexes within glomeruli, which followed by the activation of complement and inflammatory cells via Fc receptors. Antigens in this situation can be endogenous. Double-stranded DNA in systemic lupus erythematosus, for example, or exogenous, but in most cases aren't known. And immune complex deposits can be subendothelial, of course, subepithelial or mesangial, and immunofluorescence staining shows a granular pattern here. You can find this fraction of subepithelial deposits here, 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 so circulating form. And in basement membrane we can find some deposits here too. So the location of immune complexes in glomerulus, development in the following 4 types you can find in this picture. The first of all, it will be subepithelial humps, as in acute, for example, glomerulonephritis, post-streptococcal glomerulonephritis, or intracapillary glomerulonephritis. The second one, it will be epimembranous deposits, as in membranous nephropathy or human nephritis. And the third one, it will be subendothelial deposits, as in lupus nephritis and membrano proliferative glomerulonephritis. Like fourth one, guys, are mesangial deposits, as in immunoglobulin A nephropathy. I'll draw your attention, guys, on the structure of basement membrane. We can repeat, which consists from 3 components. So endothelial, fenestrated endothelial layer. So the 3 components of the glomerular basement membrane, and of course the third one, which consists from the processes of the podocytes. The next one, this slide shows you the mechanisms of glomerular injury, which following immune complex formation. Activation of complement under the antibody deposition, under the immune complexes and complement activation, resulting in generation of chemotoxic agents, mainly neutrophils, which release an activation of proteases, which cause like degeneration of the glomerular basement membrane, cell damage, and of course these oxygen-derived free radicals, which lead to contribute to the reduction in the glomerular filtration rate. In order to T cells immune reaction can development with the macrophages and T cells and natural killer cells reaction, which come to results with activation of nitric oxide and others activity molecules like proteases and growth factors, which can include the cytokines and chemokines reaction. To this reaction continue the epithelial, endothelial, and mesangial transformation, and of course the antigen-antibody complexes at next may lead to the local inflammatory reaction, and next to the injury of the glomeruli. Mechanisms of progression in glomerular diseases, guys, can development in two patterns, like focal segmental glomerulosclerosis (FSGS) with progressive fibrosis, which lead to the damage of some glomeruli after the many types of renal injury, and of course leads to proteinuria and increasing of the functional impairment, and tubular interstitial fibrosis, which manifested by tubular damage and interstitial inflammation, is a component of many acute or chronic glomerulonephritis. Nephritic syndrome glomerulonephritis, of course, development with acute, proliferative, or post-streptococcal or post-infections glomerulonephritis. It's about immune complexes mediated disorders, of course, which caused by the deposition of antigen-antibody complexes and containing proteins which derived from certain bacterial infections and formed, of course, in situ. Morphologically, guys, we can find here the hypercellularity due to neutrophils and monocytes infiltrations. Of course, during the first day of the disease, we can speak about hyperemia of glomeruli and the serous or serous hemorrhagic exudations, which occurs with neutrophilic infiltration of the glomerular structure. And after this infiltration, we can speak about the endothelial, mesangial, and epithelial cells proliferation. Immunofluorescence method shows us the granular mesangial and glomerulus basement membrane immunoglobulin G and M and C3 deposition, and electron microscopy methods show us subepithelial hump-like deposits. Acute proliferative glomerulonephritis, guys, I can show you right now these deposits under the electron microscopic investigation on this electronogram, and of course we can use this method to indicate the localization of these depositions. The greatest guides outcomes of acute glomerulonephritis, it always we can come to the transformation and to subacute or development of chronic glomerulonephritis. Microscopically, guys, I just want to draw your attention On the specific glomerular capillary loop swelling, which can development in this concrete case and have thickened walls and narrowed lumens. At the beginning of this disease, the lumen of Bowman's capsules is dilated and filled with exudate, and then it gets narrowed too. The mesangial matrix is considerably enlarged in volume, and of course in the severe clinical course necrotic changes may occur too. Nephritic syndrome, guides of the glomerulonephropathy with the rapidly progressive crescentic or extracapillary glomerulonephritis, is a syndrome associated with the severe glomerular injury, but doesn't denote a specific etiologic form of glomerulonephritis. Rapidly progressive glomerulonephritis guides classified in three types. So the first one is basement membrane antibody type, which development under the renal limited pathology and Alport syndrome. The type 2 is immune complexes in the greatest pathogenetically pattern of this type. So development under the idiopathic glomerulonephritis, post-infection glomerulonephritis, lupus nephritis, Henoch-Schönlein purpura, and immunoglobulin A nephropathy. And at the end, finally, type 3 associated always with the palsy immune form and development in idiopathic under the granulomatosis with polyangiitis and with the microscopic polyangiitis too. Pathogenesis, guides of subacute glomerulonephritis or rapid progressive glomerulonephritis includes always these three types, and the greatest characteristic from the first type, for example, it will be development of the linear immunoglobulin G glomerular basement membrane deposits. This type has a peak incidence at age 20-40 years, and males are affected more frequently than females. Type 2 shows characteristically granular staining and crescent formation. There is often glomerular cellular proliferation. And of course, the type 3, more than one half of the cases of the rapid progressive glomerulonephritis is characterized by the absence of anti-glomerular basement membrane antibodies or immune complexes. Morphology of this type of glomerulonephritis, guides. So histologically, we can speak about new formation like distinctive crescents which formed by parietal cells proliferation and inflammatory cells migration into the Bowman space. These crescents come in time to sclerotic changes, of course, and of course we can it can lead to segmental or concentric position of these crescents and compress the intraglomerular structure. Immunofluorescence method reveals the linear staining in anti-GBM diseases, granular deposits in immune complex diseases, and little to no staining for pulse-immune diseases, and electronogram showed us classically like subepithelial electron-dense deposits, which can also occur in this second type of diseases. So crescentic formation, you can find here on these electronograms like wrinkling of this basement membrane with the focal disruptions here and here, for example, and PET staining show us the crescent formation, extracapillary crescent formation, which come in time to sclerotic changes, and of course leads to compression of intraglomerular structure at next. As a result, the capillary loops undergo necrosis, fibrinous thrombi appear in their lumens, and of course pathological changes of the glomeruli are combined with expressed degenerative changes of nephrocytes, edema, and infiltration of renal stroma. Nephrotic syndrome, which come in this situation, and development in some like specific causes. Of course, we can divide it and classificate these causes like primary glomerular diseases, which include membranous nephropathy, minimal change disease, FSGS, and membrano proliferative diseases, and systemic diseases like diabetes mellitus, amyloidosis, systemic lupus erythematosus, and some infections, drugs, malignant diseases, and some miscellaneous pathology like Bistin allergy or hereditary nephritis. Membranous nephropathy, guys, is a common cause of adult nephrotic syndrome. So idiopathic development in most of all cases of the patients, and of course with association with the malignancy, with systemic lupus erythematosus, and drugs exposures, and infections, of course, autoimmune disorders. Formation of immune complexes, development in situ, so subepithelial and inside the GBM, always. Membranous nephropathy, morphologically, we can distinguish here the diffuse thickening of the capillary wall, which give us this term like membranous. Basement membrane here formate the specific spikes, which we can find under the silver staining. And of course here, guys, we can speak about the progressive course of this disease and the sclerotic changes which development in time. The immunofluorescence method reveals diffuse GBM granular staining for immunoglobulin and complement, of course. And of course, we can speak here about the electronograms, which show subepithelial GBM deposits, which eventually incorporate into the GBM and assume an intramembranous location. Membranous nephropathy, I would like to draw your attention on these specific changes with the thickening of the basement membrane. Of course, the specific change which showed us electronogram and immunofluorescence method, and I'll show you this schematically how look like the immunocomplexes which development in situ here. So subepithelial deposits with thickened basement membrane and with effaced food processes here. So the same picture we can see here on electronogram too. Minimal change disease, guys, or lipoid nephrosis or nil disease, the common cause of nephrotic syndrome in children. What does mean minimal change disease? The glomerulus has normal mesangial cellularity with normal open tufts. The basement membrane is always thick. No inflammation is seen. MSD results from immune dysfunction and elaboration of one or more circulating cytokines that affect the visceral epithelial cells. The diagnosis is one of exclusion. The prognosis is excellent because the treatment with corticosteroids produced a dramatic response in children. Morphologically, minimal change disease, guys, development always with the interstitial and tubular lipoid cells formation are seen in MCD and other conditions which are associated with nephrotic syndrome, with hyperlipidemia and hyperlipiduria. Immunofluorescence microscopy shows no immune deposits, and electronograms show us diffuse effacement of the food processes fusion of visceral epithelial cells. So look please here, this processes fusion, and the light microscopic show us the absence of proliferation, normal basement membrane, so minimal change pathology. Focal segmental glomerulosclerosis is a primary idiopathic disorders secondary to other known disorders. Development after glomerular necrosis due to other causes, and of course as an adaptive response to loss of renal tissue under the chronic reflux or analgesic abuse or unilateral renal agenesis, and secondary to mutations of protein that maintain the glomerular filtration barrier, for example, like podocytes protein or slit diaphragm proteins, which lead to the focal segmental glomerulosclerosis. Outcomes, it always will be chronic renal insufficiency and chronic renal failure, and clinically its development with nephrotic syndrome, which is resistant to steroid therapy, and hematuria with progressive clinical course. Focal segmental glomerulosclerosis, primarily lesion, is visceral epithelial damage, always with the affected glomerular segments. In other cases, guys, the circulating cytokines or genetic defects of the slit diaphragm complexes are implicated. Clinically, I said that we have a pure response to steroids, and there is a high rate of recurrence in renal transplants. A variant form, collapsing glomerulopathy, has a worse prognosis. Light microscopic show us sclerotic of some, but not all glomeruli, which in affected glomeruli we can find only a portion of capillary tuft, which involved, of course, and development like segmental. Immunofluorescence can show immunoglobulin M and C3 in sclerotic areas or mesangium, and electronogram reveals diffuse food processes effacement with focal epithelial detachment. Right now I can show you guys all of light microscopy changes, so you can find here sclerosis and hyalinosis of the glomeruli. At early stages, local subendothelial deposits of hyaline and fibrinoid appearance, and obliteration of capillary lumen with the narrowing of subcapsular space, and formation of adhesion between the capillary loops and glomeruli capsules. Membrano proliferative glomerulonephritis, guys, development with nephrotic syndrome. It can be idiopathic or secondary to another disorders or agents. A form of glomerular diseases that affected both the glomerular mesenterium and the basement membrane. And of course, most of these patients present in adolescence or young adulthood with nephrotic syndrome, with hematuria in future. Steroids here may slow the progression. About 1/2 of the patients, of the cases, develop chronic renal failure within 10 years, guys. Membrano proliferative glomerulonephritis categorized in 2 forms. So type first form is most common, is likely a consequence of antigen-antibody complexes deposition and complement activation. The antigens in the complexes can originate from infections or malignancy, but in most cases the source is unknown. The type 2, type 1, guys, can also be idiopathic. Type 2 dense deposits disease is due to activation of the alternative complement pathway. Most such patients have C3 nephritic factor in the serum and of course autoantibody against C3 convertase that stabilizes its proteolytic activity. Morphology, guys, so of membranous glomerulonephritis. So light microscopy show us the capillary walls which are thickened and have the appearance of wire loops formation. The neogenic substance of the basal membranes looks like spinelets between deposition of immune complexes. Also, there is sclerosis of the capillaries and glomeruli. Glomeruli appear lobular due to mesangial proliferation. The capillary walls often have a double contour appearance, tract appearance, due to interposition of cellular elements, mesangial, endothelial, or leukocytes between the reduplicated capillary basement membrane. And of course, immunofluorescence microscopy gave us a possibility to divide this pathology into 2 types. The first type is occlusional granular subepithelial and mesangial immunoglobulin fractions like C3, C1q, and C4 deposits. And type 2 give us information about irregular, granular, or linear deposits of C3 on either side of the basement membrane with occlusional circular mesangial deposits, immunoglobulin G, and the same one, C4 and C1q, are absent here. And electronograms showed us type 1. You can find here, so subendothelial electron dense deposits. Type 1, yes, deposits on this scheme you can find them. And type 2, characteristic like laminar, ribbon-like electron dense deposits in the glomerular basement membrane, so like here. Isolated glomerular abnormalities like immunoglobulin A nephropathy, Alport Syndrome, and thin basement membrane lesion, or benign familial hematuria. So the Berger disease or immunoglobulin A nephropathy pathogenetically, guys. So it will be genetic or acquired defects in immune regulation. These results give us increasing of mucosal immunoglobulin A secretion in response to ingested or inhaled antigens, increasing of systemic immunoglobulin A or qualitative alterations in the immunoglobulin A molecules leads to augmented deposition in the mesangium and subsequent activation of the alternate complement pathway. Clinically, patients are typically present with cross hematuria following a respiratory, gastrointestinal, or urinary infection. The hematuria typically lasts for several days, then subsides, only to recur. So light microscopy of this type of nephropathy show us glomeruli can appear nearly normal, showing only subtle mesangial hypercellularity, or can have focal, proliferative, or sclerotic lesion. And of course, immunofluorescent picture give us mesangial deposition of immunoglobulin A, C3, and pro-PRD deposition is typical. Here you can find the yellowish and greenish zones with localization of the same of these components. Electron-dense deposits in the mesangium we can see on the electronograms. Alport Syndrome, guys, is a rare X-linked disorder which caused by a defect in type 4 collagen. It's manifested by hematuria progressing to chronic renal failure associated with nerve deafness, lens dislocation, cataracts, and corneal dystrophy. The most common mutation causing Alport in this specific can, which coding for the alpha 3, 4, and 5 chain of type 4 collagen. Morphologically, guides, electronogram show us the irregular photo on the basement, thickening basement membrane with the specific splitting and lamination of the lamina densa, which often produce and distinctive basket wave appearance with the similar alteration can be found in the tubular basement membrane here, and of course we can see the specific thinning or specific thickening alternating with attenuation here. Thin basement membrane lesion with the benign familial hematuria, development with benign clinical course, and is also the result of mutation in genes coding for glomerular basement membrane type 4 collagen, and hence may be considered as part of a spectrum of diseases that includes hereditary nephritis. Of course, when we speak about Alport syndrome, we can use here, in contrast to Alport syndrome, the hearing loss, ocular abnormalities, and family history of the renal failure are absent here. Summary Meyer of Meyer primary glomerulonephritis, you can find, guys, here. So the diseases like post-infections glomerulonephritis, Good-Pasteur syndrome, and chronic glomerulonephritis, and membranous nephropathy with minimal change disease with the focal segmental glomerulosclerosis, membrano proliferative glomerulonephritis type 1, dense deposits disease, and immunoglobulin A nephropathy, development with nephritic or nephrotic syndrome, clinical presentations with hematuria or chronic renal failure, of course. I would like to draw your attention here on the immune complexes localization, of course, which lead to the light microscopy, fluorescence microscopy, and electron microscopy changes. And the last glomerular lesion associated disease like Henoch-Schönlein purpura, which development in children from 3 to 8 years. Purpuric skin lesion we can find here, abdominal symptoms, and arthralgia, and of course the combination of hematuria and nephritic syndrome and or nephrotic syndrome. Glomerulonephritis are always associated with mesangial immunoglobulin A deposition here. And Diabetic nephropathy, which development like the commonly marked by glomerular disease, which lead to proteinuria with or without nephrotic syndrome, guys. And you can find here sclerotic nodules on this microscopic picture of nodular glomerulosclerosis, Kimmel-Still, Wilson's disease. Morphologically, you can see here the thickening of the basement membrane of the capillaries, diffuse mesangial sclerosis, and nodular glomerulosclerosis like Kimmel-Still-Wilson disease symptom. Glomerular lesion, which associated with systemic diseases, which includes the bacterial endocarditis-associated glomerulonephritis due to immune complexes, amyloidosis, and other systemic disorders like Wood-Fester syndrome, polyarteritis nodosa, allergic vasculitis, and vaginal granulomatosis, essential mixed cryoglobulinemia, and plasma cells, of course, dyscrasias. Renal amyloidosis can development like secondary form under the chronic infections, purulent destructive diseases, rheumatic diseases, of course, and malignant neoplasms. Chronic glomerulonephritis is the common stage of the number of different entities. Some areas without clear antecedent, guys, and of course we can use here like statistic. You can see that most of all leads to the chronic glomerulonephritis, FSGS cases, and of course membranous glomerulonephritis, and immunoglobulin A nephropathy, rarely post-streptococcal glomerulonephritis or acute, and the greatest one, it will be the subacute glomerulonephritis or extracapillary glomerulonephritis. Clinical cause: the patient with the chronic end-stage glomerulonephritis frequently develop hypertension, other secondary manifestations of uremia, which include pericarditis, uremic gastroenteritis, and secondary hyperparathyroidism with nephrocalcinosis and renal osteodystrophy. And the next pattern of diseases which affecting tubules and interstitium. So inflammatory involvement of the tubules and interstitium, it will be tubular interstitial nephritis, and ischemic or toxic tubular injury, which lead to acute tubular injury and the clinical syndrome of acute kidney injury. You know, guys, that pathology of kidney is organized into 4 anatomic categories. So diseases of the glomeruli, of the tubules, interstitium, and vessels. So we spoke about glomeruli, we spoke about vessels, and right now we will speak about tubules and interstitium. Tubular interstitial nephritis, a group of inflammatory kidney diseases that primarily involve the interstitium and tubules. In cases of tubular interstitial nephritis caused by bacterial infection, the renal pelvis is prominently involved, hence the more descriptive term like pyelonephritis. Acute pyelonephritis, guys, ascending infection from the lower urinary tract, and importantly and frequent route by which bacteria reach the kidney. You can see here the schematically how look like hematogenous infection and ascending infection, how look like the differences between the microscopically kidney changes, and of course the hematogenous spread is far less common than ascending infection, and acute pyelonephritis may result from seeding of the kidneys by bacteria in the course of the septicemia or infective endocarditis. Acute pyelonephritis grossly look like on the cut surface we can find the swollen kidney reveals many small yellowish microabscesses which involve in cortex and medulla. This pattern of acute pyelonephritis is most typical of gematogenous dissemination of infection of the kidney in patients with septicemia. Acute pyelonephritis microscopically, you can see here platellar and leukocytic infiltration of the pelvis and calyces, and areas of necrosis in the mucous membrane are observed. The renal tubules are under the condition of degeneration. Their lumens are obstructed by desquamated epithelium and leukocytes. The interstitial tissue is edematous, plethoric with focal or diffuse inflammatory infiltrations. The complications of acute pyelonephritis, guys, is necrosis of renal papille, renal carbuncle, acute or chronic abscesses, pyelonephrosis, pyelonephritis, paranephritis, parenal abscesses, and sepsis, of course. Chronic pyelonephritis, guys. So, clinico-pathological entity in which interstitial inflammation and scarring of the renal parenchyma are associated with the grossly visible scarring and deformity of the pelvic calyceal system in patients with the history of, for example, chronic obstructive pyelonephritis and chronic reflux-associated pyelonephritis. Macroscopically, chronic pyelonephritis is an asymmetrical kidney disease. The kidney have a tuberous surface. The pyelocalyceal system is deformed. Deep scars in the cortex and area we can observe on the cut. The calyces are dilated. Their walls are thickened and have whitish color. So, grossly, external surfaces show extensive scarring from chronic inflammation with recurrent urinary tract infection. Microscopically, chronic pyelonephritis, guys, you can find here in the left panel a lot magnifications is a large collection of chronic inflammatory cells here, mononuclear infiltration in a patient with a long history of multiple recurrent urinary tract infection. Lymphocytes and plasma cells characteristic of chronic pyelonephritis are seen at high magnification, which you can see on the right-hand build picture. Over time, there is increasing of the tubular atrophy with the prominent casts like so-called thyroidization and interstitial fibrosis, which eventually affects renal vascular flow, and there is progressive sclerosis of glomeruli, which lead to the glomerular filtration rate changes, of course, and which lead to the nephrogenic arterial hypertension, chronic renal insufficiency, and uremia in future. And acute tubular injury or necrosis. A clinico-pathological entity characterized by damage to tubular epithelial cells and an acute decline in renal function, often associated with the shedding of granular casts and tubular cells into the urine. So clinically, we can use here term like acute tubular necrosis, and rarely we observed in a kidney biopsy, so like acute tubular injury. So how look like acute tubular injury under this necronephrosis? So we have two pathways to this process due to toxic injury or ischemia. Ischemia lead to vasoconstriction, toxic injury lead to tubular injury directly, and ischemia due to through vasoconstriction can lead to tubular injury too. After this development like tubular backleak, like sludged cells formation and interstitial inflammation in the answer. And of course, all of these components of this pathway leads to decreased of the glomerular filtration rate and decreased of the urine output. And of course, through abstraction, we can come to these two outcomes too. Acute tubular injury and necrosis look like with the damage of epithelium of tubules, which ranged from undergoing necrosis with acute tubular necrosis from ischemia. In this case, heart failure with hypotension precipitate the acute tubular necrosis. And next, I would like to speak with you guys about chronic kidney disease. I use this activity and show you how look like glomeruli under the different situation with the kidney damage. For example, this term describes the final common pathway of progressive nephron loss resulting from any type of kidney disease. And the first stage of chronic kidney disease, which named kidney damage with the normal or with the increase of the glomerular filtration rate, which is 90 and more than 90. So we can find here underlying condition and comorbidities. The second mild stage with the decreasing of the glomerular filtrate rate to 60 from 60 to 89 with estimate the rate of progression. And the third stage with moderate evaluate and treat the complications with the glomerular filtration rate from 30 to 59. And of course, the fourth one with the severe like with the some kidney damage with the severe changes and with the glomerular filtration rate which decreased to 15 from 15 to 29, and it needs prepare for renal replacement therapy here. And the fifth stage with kidney failure, which decreasing of the glomerular filtration rate less than 50, or dialysis, which needs the dialysis or transplantation if uremic. Chronic glomerulonephritis, guys, under the Masson-Giron preparation, shows complete replacements of virtually all glomeruli by blue staining collagen. Grossly, the kidney are symmetrically contracted with diffusely granular surfaces and triant cortex. Microscopically, glomeruli are completely effaced by hyalinized connective tissue, which make it impossible to identify the cause of the intense and lesson. There is the marked tubular atrophy. You can find here on this picture these specific changes, and of course dialysis changes, which includes arterial intimal thickening, acquired cystic changes, and calcium urate crystal deposition. Cystic diseases of kidney, which divided on three types, like autosomal dominant polycystic kidney disease, with the bilateral process, and with the specific mutation of the gene, with development of the proteins and ciliated tubular epithelium damage. The cysts are not typically present at birth but develop slowly over time. And the second one, it's the autosomal recessive polycystic kidney disease with the bilaterally and symmetrically enlarged kidney. Is shown here on the cut surface on this picture. Of course, the numerous of these cysts are small, about 1 to 2 millimeters in diameter, and this condition is most often present from birth. And cystic disease of the kidney, like acquired renal cystic pathology. Of course, this patient has chronic renal failure and who undergo hemodialysis for many years and may development like multiple cortical cyst pathology. And as a result, the obstruction with greatest speed of development of interstitial fibrosis and or oxalate crystal deposition in end stage of the renal disease. Urinary outflow obstruction can development under the two pathologically patterns under the urolithiasis and hydronephrosis. Urolithiasis is calculus formation at any level in the urinary collected system. You can find here a distribution, the percentage of distribution by these types of stones. And of course, I would like to draw your attention on hydronephrosis types with the congenital and acquired type, which lead to urinary outflow obstruction too. Obstructive uropathy grossly look like the obstruction to the flow of urine in the urinary tract, which can occur anywhere from urethral meatus to the kidney calyces. This kidney has been opened coronally to reveal hydronephrosis, and the cause is a calculus at the urethro-pelvic junction, like here. And this kidney shows a marked degree of hydronephrosis with nearly complete loss of the cortex. And hydronephrosis grossly, you can find guys on this picture kidney shows a marked degree of hydronephrosis. So dilated pelvis and calyces, and the cortex is present but reduced in thickness. And at the end, I just want to speak with you about the pattern development of tumors in the kidney parenchymal and stromal component. You know that we have benign and malignant tumors of this region, and the greatest one from the malignant tumor is the renal cell carcinoma. Grossly, this malignancy tumor development in the lower pole of the kidney. It's large but still fairly circumscribed, typically for the localized growth pattern for years, while the neoplasms remains clinically silent. You can see here the white, yellowish, brownish, and hemorrhagic red and cystic lesion on this picture. And histologically, renal cell carcinoma look like the development of some areas with neoplastic cells which have abundant clear cytoplasm and are arranged in nests with intervening delicate vessels. So about 3/4 of renal cells carcinoma have this clear cell pattern. Thank you so much, guys, for your attention. See you then during our classwork.